Dr. Dave, welcome back.
Andrew Lane, good to be back.
Tell me lots and lots of news, most of it Iranian Israeli news.
I'll give you some personal news to start off the podcast with a positive note. I had a really awesome morning. We have a patient, a client of ours that I'm sure is well known to you.
Hmm.
As she came to us actually. She had seen Dr. Janarious in the hospital, and it came to us as sort of a hospital follow up. And
Okay.
she had this really rare and really severe form of kidney disease that was, there, wasn't fully understood what the actual cause was, and had very complicated needs. And we've basically been her care team, kind of guiding her through that process over the last year. And I think at one point I remember, like, basically she couldn't afford the service,
Hmm.
and we were just like, cool, whatever, just pay what you can.
Hmm.
And she's been with us since then. She's one of those patients that really kind of brightens my day. I would see her for free, honestly. Very recently there was a kind of a recent episode where she spiked fever, and was really worried because she was having these fevers and we didn't know why. It, Over the course of a number of days, through just like repeated visits and doing certain testing to ensure that she was safe, we were able to keep her out of the ER and just kind of manage at home and get a resolution to the issue without like having to escalate. And I know this kind of doesn't sound like, it doesn't sound like an episode of House, but
No, this is huge,
I remember
right?
what she said to me that really brightened my day was, she said, I really appreciate the fact that you didn't send me to the ER. She's like, I
Hmm.
understand that, like, it would have been easier for you just to tell me to go to the ER and have them figure it out. But like the fact that you considered, like, hey, I have a high deductible plan, that, you know, because in sending her, obviously this would incur huge costs and bills. And the fact that she, recognized that, because I think that is one of these kind of central tenets of our practice, right? When we talk about looking at the whole patient, it's not just like mental health and physical health, but it's also like, hey, health insurance is for many people, one of the top two, line item costs in their household. It's the number one reason for bankruptcy. And I think in a lot of practices, they don't consider the financial aspect.
Yeah,
I think the fact that we do, I think, makes our practice really stand out. I think it's a really excellent thing. And when it's noticed, that feels great, right?
for
That nothing
sure.
is better than
Huge win, right? I
notice.
mean, this, yeah. But, I rant and rave about this a lot. This, tendency, the fact that so many doctors would have sent her to the ER is, life changing and terrible for patients who have a high deductible, for patients who are affected by the cost. But it's also just really sucks, even for patients that can afford it. Like it sucks to go to the ER and wait around for 6 hours while they look at you and like, you're not dying, you don't have gunshot wounds, you're not having a heart attack, just sit in the waiting room, we'll get to you when we can. And I mean, you and I know, like, they've been, I don't need to tell you, I'm preaching to the choir, but for anyone who's listening, like, it could take a day, it could take a day and a half of your life. I mean,
Yeah.
it could take so much time. Whereas if you're not in the middle of a critical event, if you've got a doctor who can work with you and get you into diagnostic testing without having to sit around the ER all day to wait for it, I mean, it's just such a lifesaver. It's such a quality of life improvement. I mean, I feel like we've both, I feel like we can count half a dozen patients who've told us stories about they just needed one test done at the hospital, but they had to wait around an entire day or day and a half at the ER to get it done.
Yeah. Yeah. I mean, you know, it's a really common phenomenon in medicine that I've witnessed countless times, where the incentive structure for most employed physicians in many cases is like, hey, I just want to see the bare minimum patients I can and get out of the office and collect my salary. I mean, there are some who will really strive to see more patients to get bonuses, but a lot of people, They're here for the salary. They're here because they don't want the hassles of managing a practice and after hours calls, right?
Yeah.
So it's very common that, like, if a patient comes into a doctor's office or an urgent care or something like that, and they have a symptom that could be an emergency, for the staff to be like, oh no, we don't deal with that here. You need to go to the emergency room. So, like, for example, if a patient comes into, like, I used to work in a very busy urgent care. So when the patient would come in with chest pain, the snap reaction of a lot of the nursing staff was immediately like, hey, this is chest pain. That's a medical emergency. You need to go to the ER.
Yeah.
And, they're thinking of it from the perspective of, hey, we're already overwhelmed with all these other patients. Let's offload us. But that's a very common refrain that I see all the time. And, most of the time, the chest pain turns out to be something benign, right? Odds are it's not going to be an emergency, right? But
Mhm.
the way the culture of medicine is, the way the financial incentive structures are, it does lead a lot to this. Hey, that's someone else's problem. Hey,
Yeah.
go see a specialist for this.
And it
Hey,
just feels like such a cop out on the patient end. It just feels like such a cop out. It's like, this as a consumer, as a patient, you could see the wheels of liability, calculation turning in a physician's mind. You can say like, oh, okay, they think there's like a 0.1% chance that they might get this wrong, so they're trying to punt to someone else. Or it's like, part of what you're describing is how these businesses of medicine are fine tuned to very specific factory medicine style, things. It's like, this is what we do here. If it's outside of this, if it's not we're a hammer, and if it's not a nail, we're sending it somewhere else. And it's like, dude, you're not a hammer. You're a Swiss Army knife. You can do anything.
yeah, I mean, from the perspective of the organizations, I mean, it depends on how the organization runs, right?
Yeah.
But yeah, depending on the organization, there may be financial benefit to them going to the ER and getting their care there, in the sense that,
Right.
they don't make a whole lot of money if like a primary care doctor sees them for an hour and bills for an hour to the insurance. The payout for that, as we know, is insultingly low. Whereas if they go to the ER and it's their ER, if that's the same work, then, obviously that they're billing the insurance a lot higher. Not to say they do that for that reason, but I'm just saying, like, that because of the way we've structured reimbursements for primary care. Primary care is generally, if it's a large organization, like a multi-specialty, organization, or a large hospital group that owns a practice, they're
Mhm.
not really making any money from primary care. In fact, they're probably losing money on primary care because the insurance payouts are so low. They're making money more when they go see the specialist or in the hospital, right? So that's why, people have come to look at primary care as this sort of referral factory, right? People don't. I'm going to keep it 100, as the kids say. There, people don't respect general practice family medicine. I probably said this on the podcast before, but I'll say it again. I went into family medicine, I think, kind of for that reason, right? I went to med school in a U.S. based med school. Like, it's not like family medicine was my only option. I could have picked anything, but I chose this because I really believe that what we do, primary care, is the most important and the most challenging aspect of healthcare. And the reason it's so frowned upon is because, the reimbursement structures have made it such that people can't really practice primary care anymore. Meaning, if you're in a clinic that's seeing 25, 30 patients a day, like adult patients a day, which happens, not uncommonly, there's zero chance you're doing a great job with every one of them, right? Especially because you get a lot of, when you get even like a handful of older patients who are on like 20 medications. How are you going to bang that out in a 15-minute visit?
Yeah.
you
Yeah.
you can't. And so it's not that these doctors are less than, or they're incompetent, but it's because they're being, tied to a system where they can't really practice.
Yeah.
We're making a system where, we are actually able to really fulfill truly what we're supposed to do in
Yeah.
developing this super comprehensive care.
Yeah. Yeah, stop me from using the word holistic, but it definitely applies in many ways, right? Like
Yeah.
yeah, and I'm so proud to be a part of something that is like, not using cop outs as much, right? And I know, I know when we started working with ADHD patients, I know that there was an ingrained mentality of, I know the entire industry is saying like, don't serve these people, send them to a specialist, send them to a specialist. This is just one of like, probably dozens or hundreds of areas of medicine where physicians are being trained like, don't touch this, it's liability. Don't touch this, you're not a specialist. Don't
Yeah.
touch this, it's special. And it's like, with training and thoughtful consideration, there's ways to bring more care under the broader umbrella of family medicine.
Yeah, in that ADHD space, like the patients that really stuck out to me and kind of meant the most to me actually were the really complex patients where traditionally they tell you, either to be either super cautious or just to not touch, right? So like
Mm-hmm.
we have our patients, we have some patients who came to us who were on Suboxone therapy. They have a history of opiate abuse, right? And when, particularly in primary care, but I bet you, not uncommonly in psychiatry, when they see someone coming in who has a history of opiate addiction, is on Suboxone, they'd be like, like that, I'm not
Yep.
giving this guy drugs because they're just going to abuse him. But we know, because we were very thoughtful in how we approached it. We obviously, we went to tons of absurd conferences. We actually met, people who are experts in the field and use them as consultants. And, we were able to treat some of these people that I think would otherwise basically be shut out of treatment. And
Yep.
we know from, our deep research in ADHD that the reality is that, ADHD is a major risk factor for
Mm-hmm.
drug addiction, opiate addiction.
Yeah.
It is very likely the ADHD which may have contributed. And in fact, in many cases, and in fact, there's even a study that was interesting in like cocaine use, where
That's
when
right.
you treat them with stimulants, their drug use actually decreases. There was that one study that looked at
I'm
that.
pretty sure I stood up at a conference and brought that to someone's attention.
Yeah,
And and then one of the women on the panel said, "I'm actually a co-author on that study." And I'm like, "Great, you're making my point for me. Why are people so difficult about this?"
that was pure magic to watch. For give a background to people just listening, wondering what we're talking about. When we started this whole practice, we went to countless CME conferences together in all different areas, looking at everything in the mental health range to alternative medicine. I mean, we were all over the place. We were a jet setting bunch. Andrew, I would always bring Andrew along with me, because the thing that he does really well that I'm not as great at is just like talking to random people, right? Yeah, especially in some of these conferences or your field, you feel like an imposter. And what was hilarious about that is, like, we were in this conference, we're having this serious discussion, and they're opening it for questions, and it's all these MDs, asking their questions. All of a sudden, it's Andrew, who no medical background at all, asks a question, asks a series of questions about ADHD that just bring down the house and have everyone talking. And at the end of the conference, like, everyone knew us, right? And that's actually how we got some of our consultants in the space, right?
That was fun,
So
man.
that was
Yeah.
it was an awesome thing to behold.
Yeah, and it just opened. I think it just further, underlined this understanding that I've got of one aspect of the medical system, which is this kind of deep liability fear mindset, right?
Mhm.
Which keeps doctors sending patients to the ER instead of troubleshooting, right? And I know we started down this particular conversation rabbit hole with this patient is so grateful that you took the time to be thoughtful and deliberate and troubleshoot her condition. But I think it's unfortunate for the American consumer, right? For people within this broader umbrella of health systems, that med schools are turning people out who are trained to be liability minded very early on, right? It's like we want. I think it's better for America. For doctors should be deliberative, doctors should be cautious, doctors should do no harm. But some of the harm that people are worried about is it's not harm from practicing good medicine. It's harm from what if I make a mistake? It's like,
PYA medicine. And
yeah,
so
it's cover your ass medicine. Exactly.
I
It's
love that you
terrible.
brought this up. That's such an important point. And it's so funny. You see this huge contrast between me and Mrs. Dr. Janarious, right? Because her predominant function is she is a hospitalist. She's the
Hmm.
director for a hospital. And, you know, in a hospital setting, it's obviously high acuity. You're meeting these people for the first time. They don't know you. And there is a lot in the hospital. Everything is a concern about like making sure you did everything by the book, you know, for liability, obviously to practice good medicine, but also there's that liability component. And while that's good, we do want people doing things by the book. There are realms where that falls apart. And I'm going to give a perfect example. So we recently had a patient that had come to me with a history of being diagnosed with seizures. And the seizures she described to me, while they could be seizures, they're not classic seizures. They're kind of an odd presentation for seizures. While they could be seizures, I suspect it may be a misdiagnosis, right? And so I asked, Afra if she could see this patient independently to kind of help suss it out. And she
Hmm.
was like, yeah, I'll see her. In the meantime, make sure she's not driving. And I was like, she's been driving this whole time. She's like, yeah, but if she has a seizure and gets an accident, then you're liable. And I was like, Afra, they're not suing me. Like, I was like, these are my friends. They're not suing me. Like, and I wasn't being flippant in her case. I mean,
Yeah.
this person's last reported potential seizure was many years ago.
Right.
So, but there is a harm, for example, if I take someone's ability to drive away, if I report them to the DMV and say they
Hmm.
can't drive because they're having seizures, that's a massive harm, right? I
Hmm.
mean, you lived in California. Florida's kind of like that, where if you don't have a car, like good luck. We
Yeah.
don't,
I mean, you're going to lose your job. You're going to get depressed. Your whole life's going to fall apart.
yeah.
Like, I mean, this is what will happen if. And yeah, I'm glad you were able to parse the nuance there and realize like the seizure thing is not super new and current, and the driving thing is omnipresent, and
Yeah,
we probably don't need to take their license away today.
exactly. And that's where, doing this kind of work really it is getting to know the people, right? That's
Which is
really,
hard to do if you're stuck into a 9 minute or 15-minute appointment, right?
yeah.
If you're in a 15-minute appointment slot, you're not even getting 15 minutes of talk time with the patient. You're
And there
getting
are
10
strategies.
minutes.
It's funny because, like, if you notice, we have a number of patients that followed me from my last practice, right?
Oh, I noticed. You're a popular guy. Yeah.
And not to brag, but I've always generally been someone who's popular with patients. Like even when I used to work in the urgent care in California, generally urgent care ER doctors, we have relatively low patient satisfaction score because they don't know us. They're there because they're sick. But my scores were always above the average for primary care, which has the highest patient satisfaction scores. And when people would ask like, how do you do this? Because I'm not slow. I'm relatively quick and efficient. People would always ask like, how do you do that? And I was like, well, there's really two strategies. Like one, the first thing is like, just go in there and ask how you can help them. And for the first like 1 to 2 minutes, just look them directly in the eye and don't interrupt. Most people will run out of things to talk about, after a couple of minutes. But, the fear that doctors have is, hey, I only have 15 minutes. I can't let them talk too much. I got to get to the point.
Hmm.
Obviously, when you're cutting people off, you remove that kind of connection. And the other thing is like, take a social history. And when you find anything interesting, that you find interesting, like, oh, I'm a musician, I play, I'm in a, Kiss cover band or whatever it is for a living, ask them about it. Ask them questions about themselves, right? Because everyone's favorite topic is themselves. And that is, and if you do those two things, it is, you find your ability to connect to people increases exponentially. And with time, maybe in the first couple visits, you may actually have to run over. It may be a 20-minute visit or a 25
Yeah.
minute visit. But with time, those visits will shorten because you guys just know each other well, and you can parse through a lot of the nonsense. You can skip through all the CYA nonsense because you know and trust each other.
Or even beyond that, you have greater context to weigh in that CYA,
Yep.
thing. Like if you know that someone has been driving for the last 20 years and not had a problem driving, even though they have seizure concerns, that's different than if you've got 9 minutes with the person and you're looking at check boxes and you're like, okay, yeah, by the way, procedurally, I'm taking your license away and we're doing this and we're doing that. It's like
And
it's
be sure to get your flu shot and your COVID shot.
and be sure to get your flu shot. And yeah, it's just, I mean, it's well, you're caring for children, you can't care for children and have seizure disease at the same time. We're gonna have to take your children away next. And it's just, I mean, this is yeah, I mean, I hate that part of the business, right? And a lot of it's driven by incentives, not that people have an incentive to be harsh, but it's top down. We're going to pay family medical doctors and primary care doctors less. And so they're going to become more important to generate referrals, which is going to mean like, they're going to do more referrals and less care themselves, which means as they do less and less care, it becomes less and less the norm that they do the care. Therefore, there's even more of an incentive to say, well, primary care doctors don't really do that. You better refer it out, even though it's easy. Like, even though you did a lot of it in med school, but now you're not going to do any of it anymore. You're just going to refer. And it's
Yeah.
just it's this feedback loop that just leads to not doing anything and writing referrals. And it's really upsetting.
It's funny that you say that because, like, the one thing I think when it comes to like delivering care at scale, I think Kaiser Permanente is actually one of the best systems out there. There's a lot of people that kind of disparage them for a whole host of reasons. And yes, they have there's downsides to the Kaiser system. But one thing that I do think was pretty excellent was the fact that, for those who don't know, Kaiser Permanente owns the hospital. They own the insurance. It's an HMO system where they are working on cost containment. So they actually lose money the more specialists and hospitalizations and all that, right?
Yeah.
The whole strategy is cost containment. So in that setting, referrals are ordered way more judiciously, meaning you're expected as a primary doctor to start treating a condition, and only if you get to a point in the road where it's something that's out of your scope or that you can't manage on your own, do you then refer. And in fact, if you refer someone for something simple, you'll oftentimes get a message from that department telling you to cancel the referral and please look up how to be a doctor. And so when I left the Kaiser system, because I was there for residency, I became a partner with the Southern California Permanente Medical Group. So I was there, as a partner there up until 2020. And I arrived in Florida, and this was my first time outside of that system in the standard fee for service kind of. I was shocked at how different it was. Like when I was talking to my colleagues who were in my last practice, they're like, "Yeah, I just diagnosed my patient with like hypertension and I'm referring them to cardiology." I'm like, what? What do you mean? That's like our bread and butter. Why are you sending them to cardiology? And, there are arguments, there are certain things that, in cases where someone has hypertension, seeing a cardiologist is a good idea. Like, for example, like getting an echocardiogram just to check out the heart, make sure there's no structural issues. Some case, there are other scenarios where it may be some benefit. But like, I see so many patients that see cardiologists longitudinally for the management of their blood pressure, and I'm like, why?
Mm-hmm.
Or
Mm-hmm.
or patients.
Meanwhile, if you want to see a cardiologist for a new and urgent problem, it could take months.
Yeah, or I have patients that have been like, basically rationing their birth control because they go to their OB-GYN to refill their birth control, and it's hard to get to them. And I'm like,
Yeah.
well, normally your regular doctor should be doing this, So yeah, there becomes a lot of siloing because there is this incentive in the fee for service world, right? Like, in the cost containment world, the cardiologist doesn't want you sending a million patients. In the fee for service world, when you're sending the cardiologist millions of patients, you get like a basket at Christmas. You know, financing my renovations to my house this year, couldn't have done it without you,
Yeah,
you know,
yeah,
kind of
yeah,
thing. So it is interesting how incentives work, and can become perverse incentives in some cases.
yeah. Well, hey, there's a couple things in the news I really want to ask you about
Yeah,
because it's never a slow news week, but and I know that we get kind of the best reactions off the cuff. So if you don't mind, I'll make a hard
yeah,
pivot for a second.
yeah,
And I saw this, and we've talked about Alzheimer's before, and this has been reported in a wide number of sources here. Common anti-seizure drug prevents Alzheimer's plaques from forming.
Keppra. Yes,
Yeah, Kepra, exactly. So you read about it. Yeah. This,
I
and I have to be honest with you, like the first time I saw this headline, it was from I'm not going to name, it was from Fox News, and it was very light on the details. I'm like, wait a second, where's the real news here? Like what's
they usually are hard hitting and very transparent from
I
off the
know
top.
they're usually huge, right? We report, you decide. They're usually great journalists, but I was struggling to find the meat of what they were talking about. I'm so glad you recognized this right away. So then I found like a slightly more serious source, like Northwestern University,
Mhm.
and then I found the actual. Then I found what I think is the actual paper, right?
Yeah,
Which of course is much harder to read the whole title out loud. Uh, but it's apparently a common drug that somehow modulates um, your body's ability to produce beta amyloid plaque.
yeah. Yeah, so yeah, Keppra is probably the most common seizure medicine prescribed. It's easy to dose. It doesn't require extensive monitoring. It generally has a really favorable safety profile.
Mm.
So it is the most commonly prescribed seizure medicine for like generalized seizures. And I think I did briefly see a headline like this about reducing beta amyloid plaque. We're always awash, right, in like new therapies that are shown to, either reduce beta amyloid plaque or, uh, you know, affect some biomarker of aging or heart disease.
Hmm.
So it is always hard to drown out what is signal from what is noise. And I haven't obviously read the
Well,
actual source literature.
or I know one of the core tensions in this reporting, or one of the core issues, is it's there. There seems to be debate and or just some uncertainty around, is the beta amyloid plaque actually causing the Alzheimer's, or is it merely
Yeah,
coincident? Is it just happening along with the
absolutely.
Alzheimer's?
Yeah, absolutely. And so that's a huge discussion because some of the modern treatments, the latest and greatest treatments in Alzheimer's are injectable um, antibodies that go and actually clear the beta amyloid plaques. But in these studies, the actual benefit hasn't been profound. There's
Hmm.
been they've kind of shown that in patients with early Alzheimer's, you can definitely kind of slow the progression of the disease with these medications, but it's certainly not this groundbreaking cure for Alzheimer's.
Right. It's not. It's generally not reversing the progression of the disease.
Exactly. So,
You're slowing it, but not. But not.
yeah, there is this question that, like, are we looking at the wrong thing? And actually, there's a book that I read, and I think it'd be worth talking about this in a future episode, by an author named Dr. Goodnow, I believe, and it's basically on the role of plasmalogens
Mm.
in the role of Alzheimer's and the development of Alzheimer's. And this book posits that it's actually not the beta amyloid plaques or the tau tangles. These are kind of downstream
I
things.
love these words. I love tau tangles. It sounds like something. It sounds like something out of the Matrix. You know. sounds like something that belongs in some Japanese samurai Matrix style movie. The Tao Tangles are coming for you.
That's funny. But yeah, I mean, in this book, they're basically positing that, that it is actually these molecules called plasmalogens, which basically are part of the membranes of cells and help determine whether the cell membranes are more fluid or more rigid, that are
Mm-hmm.
actually the drivers. And they use a lot of epidemiological data to make that argument. And obviously he sells his own plasmalogen supplement, which makes you question it.
Yeah.
But it is, this is such an interesting debate because we're clearly not there yet, in terms of knowing what is the actual cause and what is the actual approach.
Mm-hmm.
What I and what we're the really exciting breakthroughs in this field are this kind of molecular diagnosis of Alzheimer's, right, where we're able to do a phosphorylated tau and possibly detect the pathology of Alzheimer's, over a decade before the actual symptoms start.
Yeah.
So this is a huge breakthrough. But then the question is, well, if we detect early development of beta amyloid, would actually, using some of these beta amyloid removing treatments to prevent them from accumulating in the first place, would it prevent the onset
Would
of
it stave
Alzheimer's?
off? Yeah. Would it stave off the onset of the disease?
And
And
there
we
are
won't. We won't know until another 10 or 20 years passes where there's
well, there's actually ongoing clinical trials
okay.
that are enrolling now.
But it takes time, right? I mean, the process of finding out is to
Yeah,
get
and well, it wouldn't
hundreds
take
or
20
thousands of
years.
patients.
I
Good.
imagine
Okay.
it would take
I'm glad it won't take 20 years, but
I
maybe it'll take
imagine
5
you'd
or
be able to
10.
get some like 5 to 10 year
Okay.
range, get some significant answers.
Yeah. Good. Good. Because we need answers, and part of the method to find out is to to say like, okay, well let's get a cohort of patients and let's prevent them from ever forming or further developing amyloid plaques. And if we do that, is it the case that none of them develop Alzheimer's, or do some of them
Yeah.
still develop Alzheimer's?
Now, but
Um,
switching back to this medicine that, and
Kepra.
again, this is, I haven't read it. I don't know what everything's, but I'm going to tell you before I even read it, how I approach anything that's kind of a novel therapeutic, right? For the things that you see in the news, like that purport to have some benefit in this. This is how I
Yeah.
always break it down. One is, I begin with, is there a reasonable mechanism by which this medication would actually give benefit? Okay, then do we have any like convincing animal data that suggests that this is, could affect us on the biologic level? Could it be effective? Obviously animals are not the same as humans, but they have a lot of the same physiology as us. So, if there's positive animal data showing that you give Keppra and it reduces the, Alzheimer's plaques or the onsets of rat Alzheimer's, great. Then we look, is there anything in humans that would suggest this benefit? Now, it doesn't necessarily have to be a trial on Keppra looking at, specifically at reducing Alzheimer's, but perhaps there's observational data out there that show that people that have been on Keppra, have less incidence of
Mhm.
Alzheimer's. So I'd be looking at that. And then if after that, what I'm looking at is, what is the cost in terms of both safety and actual cost, right?
Yeah.
And that's how I kind of balance it out. Like, so for example, let's say that this does have a mechanism, it has rock star animal data. We see that in observational data, people taking Keppra have less, have less seizures, and we determine that the safety profile is really benign and that it's, dirt cheap to afford. Well, then that's something that, like, hey, if you're at high risk and you want to consider supplementing, I think that's something that, hey, may be worth a try, right?
It's $9 a month.
Yeah,
Right.
it
I don't
is.
want to sell. I don't want to sell it right now, but it's yeah. It's one of those. It'll be interesting to maybe have a follow up discussion and kind of go through that framework you're discussing here on
Yeah.
what's the mechanism and what's the animal data, what's the human data say, because
Now, I will say on seizure medicines, people don't love being on seizure medicines because
Oh,
There
come on. They're so fun. They're so fun.
there tends to be, some
My favorite times are our annual ski trips when we light up those seizure medicines.
crushing them up and storing them off the mirrors. Yeah.
Right. Right.
But I mean, seizure meds in general are kind of known for their cognitive dulling effects, making people feel
Dang.
tired, fatigued,
Dang.
irritable in some cases. I think,
It
a
sounds
better
like me after every lunch and dinner meal, but yeah.
exactly, exactly. It's basically like having the meat sweats constantly. But no, but I think Uffer would be a better person to, because I'm not, obviously I'm
Yeah,
basically
well,
one for the machine.
I'm so excited to see this field developing, right? Like to see the development of this. I know that one of our early episodes was talking about the new blood markers that can confirm the pathology of Alzheimer's, present or not present in individuals.
How do you say Alzheimer's?
I say it however you say it, of course.
I heard a T in there.
Yeah, there's definitely no T. It's a Z. It's a Alzheimer's. It's not timers. It's not definitely not all timers.
You just pronounced it in a way that made it sound like more Jewish. Like you made it sound almost like you were saying it like Yiddish or something there.
Alzheimer's. Yeah. I have to admit that I can never spell Alzheimer's, and
I
I'm
can't spell
ashamed.
it either.
I'm ashamed. I'm ashamed. It's one of the most profound medical conditions of our time, and I can't be bothered to pronounce it or spell it. But it's definitely on our radar, right? I got a spot in
Yeah.
my brain that matches to it. Um, well, I again, I'm really stoked on the development in this field, right? Like it's clearly not rising to the level of taking Kepra every day for everybody, but it's exciting to see that there's ongoing work.
Yeah, I mean, I just read through so much of the stuff that like I'm always have this very tempered excitement for things, and
Mm.
for me, it takes a long time of like kind of reading and evaluating before I
So
will
let me
recommend.
pull on that thread a little bit. Let me pull on that thread a little bit because I hear what you're saying. Part of what I hear you saying is like I'm a little numb and lacking in excitement when I read these things because I read so many of them. There are so
Yeah,
many of them, and I think maybe that's an important thing to point out to listeners, to patients, to friends and family who we see people get excited, and I know you've got a framework by which you kind of evaluate some of these. Longevity optimizing off-label drug uses, right? Like rapamycin is a big one in this field, and Jardiance is another big one in this field. But I think it's important to point out that based on what you're saying, and I see it too. There's headlines every day of like this drug conveys this benefit that might be revolutionary. If you went off of every headline and just started randomly taking all these drugs, it would never end. I mean,
yeah,
this is not. It's critical that you've got this framework, and it's critical that medicine does have a cautious approach to ascribing treatment and therapy. Because if you merely went off of every headline, whether those headlines are in Northwestern Now or in Fox News or even JAMA. If you went off of every headline, you'd be on, 87 different medications, and you'd definitely be having some unique side effects that no one ever knew about because you're a completely uncharted territory at this point.
yeah, absolutely. I mean, yeah, exactly. I mean, there, there's a cost to all of this, right? And in some cases, people take these kind of things and they do have side effects or reactions. And then there's just like the cost, right? Like I'm very, I try to be very in touch with like the finance side, as we, talked about in the beginning. And, you
Yeah, like
know,
a cost benefit analysis for the
exactly.
patient.
I
Yeah.
just, when patients are excited about the latest and greatest, I do try to factor that in. It's like, well, this particular supplement, uh, while it, you know, does seem appealing based on the headlines and maybe some animal data, if you're paying like $200, $300 a month or whatever on, some specialized supplement, probably that money could be spent elsewhere
Yeah.
and get much more benefits. For example, a physical trainer to improve
Yeah.
your VO2 max, or you know what I'm saying?
Yeah. 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 It's a great point. It's a great point. But I do still recommend red light therapy, especially on the nether parts of your body. But
And that's another thing that when we started this practice, I was very sensitive to. It's this: I cannot stand this idea of not being able to hold two truths at once, right? Like, meaning, in the conventional realm, there is this obviously dismissiveness of the alternative realm. Um, and obviously, the likewise in the alternative realm, right? With we see in, like, Casey Means' book, where she basically says that your doctor doesn't know anything, and there's this dismissiveness. And in the alternative medicine space, though, I would say it's more malignant in terms of its dismissiveness. Because the thing about, you'll see it in the conventional medicine space. Let's say you have a conventional medicine doctor and they just say, oh, all this alternative medicine stuff is nonsense. At the same time, they are still cautious in their recommendations of, like, conventional medicines, meaning they're not throwing every single human being on a statin and on Wegovy and all this stuff. They are
mhm,
kind of at least trying to select the population. But what I see a lot in the alternative medicine spaces is this sort of one size fits all. Be on the Wolverine stack. Be on the longevity protocol. Be on the what
the Wolverine stack. Yeah.
Brian Johnson, like, Android protocol or whatever. And they're clearly, like, selling this stuff sort of as a sort of one size fits all. This is the answer to everything. Like, I remember we went to a conference where they were talking about peptides, and in that conference, peptides are the solution to everything. They're
Yeah.
not the solution to everything.
Right.
Like, and I like, although it makes me a terrible salesman, and although I know there probably is some benefit in the placebo realm of me just talking up this meds to get the patient excited, I just don't want to be a bullshitter.
Yeah.
Like, there's
Yeah.
too much out of that. Like, it's not how my mom and dad raised me up to be. I just,
Shout out to Doctors Janarious and Dr. Janarious. Yeah. Yeah.
so that's my thought. But I need to look more into it. Yeah.
Well, let me push you one further here. I got one more article I wanted to share with you, and I feel like this again kind of speaks to a topic that's come up before.
Mm. Roundup.
Newer groundwater, yeah, Roundup, sure. Newer groundwater is associated with a higher risk of Parkinson's disease. What these researchers seem to have done is identified where they've taken 12,000 people and been able to identify where their water comes from and what diseases, whether or not they have Parkinson's. And they've been able to show a really strong association with newer water sources, less deep aquifers, having a significantly higher rate
Probably
of incident.
pesticide runoff.
Right. It's pesticide runoff. It's
So that's already been known. So, like, pesticides are a known risk factor for Parkinson's. Like, we've known that for some time.
Yeah, and maybe 2 years ago, there was a study that came out that showed the correlation between living close to a golf course
Mhm.
and Parkinson's risk, which again speaks to pesticides.
Chemicals in the grass, yeah.
Yeah, and we're talking for a second ago about patients that will spend hundreds of dollars a month on supplements. I think this kind of speaks to, like,
A reverse
how,
osmosis filter.
yeah, just buy a reverse osmosis filter. Exactly. Right. Like, buy a reverse osmosis filter before you get on the Wolverine stack or the, Magneto stack or whatever it is. Right. Make sure you're drinking RO water and drinking and cooking with RO water, because, who knows how deep your aquifer is and whether it's a glacial aquifer. And I mean, this is serious. There's serious nasty stuff in our water.
Yeah.
Full stop.
I haven't, I saw this headline, didn't read through it because I saw it and I was kind of like, no, duh. I you know, like to me, I mean, I feel like I don't have to review this that critically. I buy it,
Yeah.
you know,
But
because we already know that association, right?
yeah, yeah. But sometimes I feel like a kook though, like talking about like how important water filtration is. And I'm you know that I've long been concerned about PFAs and microplastics and all this stuff. And I feel a little granola-y and I feel a little bit like a hippie talking about it. But it's like there's definitely something in our water.
Well, see, I think your concerns, though, I think you kind of put your concerns, I think, in the appropriate order, right? Because when we first like started working together for your own health, your focus was largely like, you know, metabolic disease. Let me
No, dude, I gotta lose weight and look sexy for my wife. Come on, man.
Yeah, I mean, and yeah, and by the way, vanity, I think is a highly underrated. It's funny. I have like this patient that had some plastic surgery, and people always feel a little like, oh, are they going to judge me for But I know I think I do think striving for a good cosmetic or the best possible cosmetic
Aesthetic.
aesthetic
Yeah.
appearance for yourself is
Yeah.
reasonable, as long as you're not going to crazy extents, because
Yeah.
I do think it tends to drive good health behaviors. And also, I just think for mental health, it does something to just like what you see in the mirror, right? But to your point, I mean, what we were really hammering home was getting, the insulin resistance down, getting you off the blood pressure medications. And then it's the talk of like, should we be looking at PFAs? And, whereas I think too many people jump to these kind of like topics from the jump. They're
Hmm.
so worried about this, but they won't take a statin even though they're like
Right.
at risk for heart disease. You know what I
Yeah.
mean?
So if I heard you right, it sounds like you're affirming and endorsing an approach that starts with metabolic health, um, uh, blood pressure,
Well, no, not in that
throw
specific.
cholesterol. But if you had to rank order just a few things, if you had to rank order metabolic health, blood pressure, PFAs, and the Wolverine stack, that might be the right order to do them in.
Yeah,
Metabolic health, right? Like maybe don't
it
start
comes
with
to
Wolverine. Don't.
prioritize, right? It just Yeah, it's all just prioritizing like
Yeah.
comprehensive care. So
No,
for example,
and
if someone comes in with severe like depression, the likelihood that you're going to be like getting them to like install a reverse osmosis filter
pretty
is
low.
low,
Yeah.
right? Or
Yeah.
the likelihood that you're going to get them like worried about their VO2 max is low. They're thinking
Yeah.
about like whether they want to stay on this planet. And so at that point, the priority is mental health, right?
Hmm.
And then we'll get to the physical health. So it's all about prioritizing, right?
Yeah. Yeah. No, that makes sense. That makes sense. Um, do you have, so what are you looking at in the news? Have you seen anything interesting?
Geez, I saw some
Or
articles.
you are you just too busy saving patients' lives and
I saw an article that had, and I don't think we need to pull on. We just talk about it. Two interesting articles that had mentioned the risks of Wegovy, but I thought they were. I don't think they were fear mongering. I think they brought up some interesting points. One was talking about the risk of high discontinuation rates with Wegovy. So I
yeah.
think they cited the number about 65% of people who start on Wegovy will cycle off in a year. And I've been sounding alarm on this for a while. We did it in a recent episode where I was saying this is where you get into trouble, right? Particularly in women, postmenopausal women, they lose weight really rapidly with these
Hmm.
medications, sometimes too rapidly, oftentimes too rapidly. There is a concomitant decline in muscle mass.
Hmm.
And then they come off the medications with less muscle mass, even lower basal metabolic rate, higher frailty. And in the studies where we looked at, switching people off of Wegovy, they're going to regain statistically 2/3 to 3/4 of the weight back, if not more. And they're going to end up with an even worse body composition at the end, right?
Hmm.
And then, it can become this vicious cycle.
Hmm.
So, it doesn't mean that everybody that goes on Wegovy needs to be on it for a lifetime, although that is really what the medication was intended to be when they released it.
Yeah.
but that you have to be really cautious in your plan. Like you really have to think this through if you're planning to come off it.
Or can you afford to keep going?
Oh yeah, before even starting, you're saying, yeah,
I
yeah. I mean,
mean,
that's a definite consideration.
we've met many people who said like, I'm going to spend my last dollar on this to do it for 6 months just to lose 30 pounds. And you're like, the studies show that that's not going to be successful. Like
Yeah.
statistically, there's a 90% likelihood that will not be successful. This is a very bad plan.
Yeah, and and also like if you are one of those people that wants to cycle off, like planning for it,
Mm-hmm.
well, I know that I want to cycle off, so I'm going to focus really hard on either preserving or even increasing my lean mass. I'm going to create these built-in habits of exercise. I'm going to create structure around my diet, so that when I come off, it's not going to be chaos, that kind of thing. And yeah, you're right. I mean, also like selecting the not getting the wrong people on it in the first place, because we do have a lot of people, a lot of our clients who, wouldn't necessarily qualify for treatment, but they just want to look good for the beach. And while we're happy to kind of work with that, we obviously, when I do this kind of care, there's this huge discussion I have with them about all of this up front. And oftentimes we'll be doing, kind of microdosing or spreading out the dosing, so that they're not escalating all the way up and they're not losing weight too rapidly. So there's just, it's also I think, in the approach as well. The other article sounding an alarm on Wegovy, this was something that I've been sounding an alarm on forever, is bone density, right? There was
Yeah.
and I have to look up the numbers, but there was a study that basically showed there was an association with Wegovy and decreased bone density, and which leads to osteoporosis. Again, I want to make it clear that there's nothing magical that the molecule is doing to strip your bones of minerals. It's not doing that. It's
It's calorie deprivation over time.
it's rapid weight loss. So there
Yeah.
was a there that was done doing something called a protein sparing modifying fast, or a also known as a very low calorie diet. What these are is they're sold as a kind of brand name supplements. They're called things like Optifast, or is a commonly known one, where it is your diet is a series of shakes that equal out to about 500 to 800 calories a day, and they're high in protein. They have all the appropriate vitamins and electrolytes, so you don't run into
Mm-hmm.
those issues. But this was actually a very, very common approach to difficult weight loss prior to the GLP-1s. And in fact, Kaiser Permanente had a whole program where they would enroll people. And the results can be pretty profound, right?
Yeah.
After 12 weeks on one of these diets, which has better adherence than you'd think, you will see significant
I,
reductions in
I
weight.
yeah,
Go-
I did stuff like this multiple times. Like, yeah, I mean,
And you did do it.
not specifically the Kaiser Permanente model, but I mean, there were many NutriFast, MetaFast. There's all sorts of protocols that involve Ensure shakes, right? I
Mhm.
mean, there's like these sorts of yeah. You're right. Like these are very popular diets.
And I bet in your case, at least in the short term, it was effective.
Yeah.
And it can be a game changer for some people, like for people that have really difficult to control diabetes, or who are on that
Mhm.
pre-diabetes range. A lot of pre-diabetics go into remission. A lot of early diabetics go into remission. A lot of people on high doses of insulin come off insulin altogether.
Oh
It can
wow.
do impressive things if done right. But one thing that I pointed out is when you look at the study, I believe it's called the direct trial, where they looked at this specific question. What they found was a significant reduction in bone mineral density, particularly at the femoral neck, that's like the worst place to lose bone mineral density, because that's how you get hip fractures, right? So I think that I thought those were two good articles that are pointing out something that I've been saying for a while. So I just thought I'd bring them up because they were
Love it.
worthwhile. And there was
Love it.
another article, but it's a really deeper discussion about like the actual healthcare system and the what's going
The
on with
system.
insurance in our company. So I actually want to do that for a whole separate episode, because this is something we're going to talk about for a while.
Okay. And Alzheimer's. We're going to definitely bring up Alzheimer's again.
Exactly.
And I'll find more ways to pronounce it wrong.
Yeah. Or you You can go to like the country way of saying it, like old timers disease. He's got that
Old timers disease.
old
Yeah, there you
timers
go.
disease.
That sounds like something my 5-year-olds would say. Well, Dr. Dave, thank you for your time as always. I appreciate it. I look forward to our next conversations, and
Yeah,
I'm excited to learn more about that framework you have also for evaluating some of those longevity optimizing, lifestyle trendy off-label medications, because I know there's a huge demand for that information among our clientele and among everybody, really.
absolutely. Yeah, I'm obviously always stoked to talk about these things, and I'm always just happy that you set this one up. So thank you for that, Andrew, and thank you for everyone listening. If you found this informative, please like, subscribe, share. It means the world to
Or,
us.
or write us a letter and tell us why it was terrible,
Exactly.
and we'll
Or
do better
feedback.
next time.
Exactly.
Yeah.
Throw a brick through
Dr.
my window with an angrily worded letter.
Oh, there you go. Dr. Dave, thank you so much. Cheers for now.
Take care, man.